let me introduce to you our third and final speaker. He served as president of the European Stroke Organization for 2 years, from 2012 to 2014, and was elected full board member of the European Academy of Neurology in 2014. He is a full professor of clinical neurology and director and chair of the Department of Clinical Neurosciences and Prevention at the Danube University in Krems, Austria. He was also the chair and director of the neurological department of the University Hospital Tulln. Significant to note is that he is also a renowned personality for setting up the first stroke unit in Austria in 1997 in the same institution. Ladies and gentlemen, presenting to you our third and final speaker, the current president of World Stroke Organization, Professor Dr. Michael Brainin.
Thank you for this charming introduction. Now, I won't keep you long, but I do have the task of looking at the developments in the Philippines from a global perspective. So our mission from the World Stroke Organization is a life free from stroke. Can you imagine how wonderful that would be? It would be wonderful. So these are the faces you know. These are the faces you don't know. But to reduce the global burden of stroke through prevention, treatment, and home care is our mission. That's what we do. The World Stroke Organization was established in 2006. It's the only global organization focused on stroke. It has now, that's in all sides, over 100 other organizations under its umbrella. It has about 6,000 individual members. And the special thing now is that we have consultative status at the United Nations and the World Health Organization because we are an NCD and we are a global organization. So just a few days ago we were speaking at the United Nations General Assembly to defend the issue of unified universal health care for stroke patients. And the importance of this was carried forward in many documents. So this is the kind of thing we do. We partner with other organizations like the Non-Communicable Disease Alliance and other partners we make conferences with, and so on, like the one happening here today. So what is our strategy? Well, I will not go into that. I'll just read to you the headings. We have to increase the global capacity, and this is something where you can help. You can help us. We build awareness and knowledge of stroke. That's where you can help. What is a stroke? A stroke is everything that happens suddenly and is half-sided. Yeah? Half-sided, no movement, half-sided, no feeling, language is half-sided because it's one part of the brain, the left part mostly. Yeah? So this is suspect of stroke. So that the message is easy. Yeah? And grow a robust organization, that's what we're doing. So these are other things. We have, of course, like many other scientific organizations, we have international conferences, we have world conferences. In Montreal was the last one, before in Hyderabad, in Brazil, all over the world. We have a global policy agenda, which is on our website. We have a highly reputed scientific journal. We have an online education tool called World Stroke Academy. And we have the World Stroke Campaign and the World Stroke Day, which is on October 29. It's a World Stroke Day. And tomorrow there will be a stroke run in the Philippines and in many other countries in the world. So as I said, advocacy, global policy with the WHO, the UN, and other organizations. With the Angels program, we have decided to team up, and you've already heard what this is about, and we're very proud to have this link and collaboration, because this is one of the few very few initiatives worldwide that really make a change in the setting and in the treatment for patients with stroke. Now, altogether, looking ahead, we have other projects that are worth mentioning, like a Future Leaders Program. We have a prevention strategy, which I will extend on if you ask me to. And we have all kinds of other activities that are important to us. So don't be the one is the current slogan. So 1 in 4, one person in 4 will have a stroke in his or her lifetime. 1 in 4 in the world. Once you reach the age of 25, you'll be one of the 4. I'm sorry, but that's the case. So the message is don't be the one, or be among the 3, whatever you like. So these are the other activities that are ongoing around the world. And you can see from the dots in the chart that we are really a global organization and doing the best we can to be heard and to be effective. If you have a chance or somebody who is interested to come to Vienna, which is my hometown, we will host the largest stroke conference next year, and it will be a real big event. And of course, we will also have angel activities there. So having said this, let me make one final remark from what Professor Navarro has said. From my perspective, having now been here in the Philippines the 3rd time, I was once in Luzon and once in southern area near Mindanao, and of course Manila. The impressive thing about stroke care in the Philippines is that it has to cover a region which is extremely difficult. I would say it's maybe more easy, and Professor Hackenschul would agree, it's more easy to do it in Chile, in the Andes, you know, in the high mountains. It's probably easier to develop stroke care because it's a continuity of it all high up. But on 4,000 islands or more, it is really a big challenge. So I think apart from the numbers we are talking about, the stroke units and so on, we have to think about the geography and the diversity, the ethnicity, all these problems. And then comes, of course, the very low density of stroke-ready physicians, if I may use the term, people who know what this is about and how to recognize stroke quickly and act accordingly to treat the symptoms and signs. So my respects, Professor Navarro, and your society, your team, your work, may I say your lifelong work to alleviate the burden of stroke in the Philippines. And I hope that this day today is also successful in driving the issues here in the Philippines even further. Thank you.
Thank you very much, Professor Dr. So now we move to this portion of the conference to give everyone a chance to raise their questions about the presentations that were delivered here this afternoon by our very distinguished panel of experts. So with that, I'm turning over the microphone to my friend here, Grace, to continue.
Alright, good afternoon again, and we would like to thank all of the media people who came today. It's a Saturday, we know, and we thank you so much for coming in and having to share this very special occasion with our panel of experts and so with us also. So we now open the floor for any question and answer. Yes, Ms. March? You have a mic on your table, please. You may use it, please.
Good afternoon. I'm Marjorie. My question goes to Mr. Thomas. So you mentioned the role of the Angels consultant, but can you tell us who are the members or who comprises the team, the Angels consultant team in in every or per facility?
So the Angels consultants are young people. We choose young people that are really energetic, have a good grade from the university, not specifically medical people, but science, or sometimes also medical, that are really interested to communicate and are very open to change, to help to do change management in the hospitals. We train them intensively in a period of 3 to 4 weeks. Internally, that's me and my colleagues, but also, of course, including a lot of doctors and nurses. These consultants go to the hospitals, observe the processes in the hospital. Most effective is so-called simulation. We say dummy patient simulation. Somebody of the team, or even sometimes the ancient consultant is brave enough, or she is brave enough. She is the patient, and then we observe the processes. Somebody from the team has a GoPro camera, and then we sit together in a room like this and watch the processes. And I can tell you, so if you ask stroke teams, are you fast? Are you good? Yes, of course. We have no problems. We have a door-to treatment decision time less than 30 minutes. And then this team see themselves on the video in front of an elevator, and they're waiting 5 minutes. And they say nothing happens. That's not true. What happens is that the patient loses brain cells. And so we try to circumvent next time the elevator by different methods, and so the time is better and the quality of the treatment is better.
I would like to know who are the members of the Angels team. Is it comprised of a doctor, a nurse, in every facility or in every hospital? How many medical professions do you need to have the Angels?
This is a question I don't exactly know. So we have, as I said, our main focus is that we have highly intelligent and educated people. All of them have a PhD. Some of them are even professors, but not in neurology, because if you send to a stroke clinic a neurologist who think he knows everything best, then it's not so easy to consult this hospital. It's always good that the team itself see how things can be improved, and that we are more the facilitator than the educator.
All right. Before we proceed with the next question, apologies, Professor, we would like to introduce to you a member of the panel of experts who's seated right there, Professor Dr. Werner Hackett, former president of the World Stroke Organization. So if you have any questions, you might want to...
I can say something. The initial idea was that I would facilitate the questions that are coming and decide who would be the best to answer, but this after the presentations is certainly not needed. So I thought I make just one short comment, and that is, why do we need you, and what is your responsibility? Firstly, stroke care is a very wide arena. It starts with prevention, primary prevention, like healthy lifestyle. Then it starts with recognition. You cannot have access to stroke care if you don't know, as a patient or a relative, what a stroke is. And this teaching effort must be taken by you guys. You guys are the ones who can communicate those messages. You are also the ones who can tell them, once you have the signs and symptoms of stroke, call the ambulance. I know from yesterday evening's drive that it may be difficult to arrive quickly in this city in the next suitable ambulance. But nevertheless, it's still better than not going, okay? And it can be improved by using special signs and sirens and so on and so forth. Then the next thing is you can work on politicians and healthcare providers and ask them, what is your plan to implement stroke care in the different provinces of our country? It's usually not a national approach, usually it's a provincial approach. The provinces know best where the hubs are and where to put the centers for stroke care. That's also something that you can much more influence than an average doctor who has usually not much access to politics. And then never forget, whatever you do in the acute phase, it can be lost when there is no rehabilitation afterwards. And rehabilitation also includes secondary prevention, to prevent a second event. And here we are again. That again is, well, communication of risk factors, communication of strategies. So we depend a lot of you, and this is a very responsible position that you are in. That is what I wanted to say.
Yes, we'd like to continue on with the question and answer. Yes,
Hi, good afternoon. I'm Eli from eLifestyle Manila. To the distinguished panel, I would just like to know how you are in connection with Sir's comment about healthcare in your different countries. How was it pervasive in the survival rate of the patients, stroke patients? Because yes, we have healthcare benefits here. For private entities, it's not a general thing. Our field has a very small coverage. But what was the driver there? Was it an NGO? Was it a medical firm? Was it the government putting a lot of money into the healthcare business? Are these stroke centers being sponsored by a city, governor, or whatever? At least from our point, we would be able to understand where we can probably tell the government this is what is really needed in the Philippines.
You want me to answer that?
Yes, sir.
Thank you very much for that question. It's really a great question, and I really appreciate that. Following the issue raised by Dr. Haki, you know, physicians are very poor in trying to advertise what we know and what we could do, right? So what we really intended to do is to bring this up to our politicians, because we wanted this to be, there should be a legislation for this matter. And the only way which we feel would be more effective is through you, through the media. For instance, after this talk that we have gone through, really you can bring out the problems to them, the national problem, the burden that we're seeing, because they got to be aware of this so that they will be able to come up with some kind of legislation in order to improve the outcome cases with stroke in our country. Just reducing the incidence, reducing the prevalence, reducing death rate will be very, very significant.
Maybe I can add a few words. In Austria and also in Germany, the healthcare situation is different. Firstly, we spend much more money per capita on healthcare. It's probably 20 times to 30 times more than in this country, number one. Number two, we do not have privileged services for private patients. Our healthcare is expensive, but it is available for everybody. and the cost is either covered by health insurances, which are legally required, or by governmental institutions for those few people who don't have it. And for example, for our visitors, people that come from abroad and get health care. And as you heard from Professor Breimin, in 1997, they founded the first stroke unit in his hospital. So that's a story of 20 years now. It's about the same in Germany. And here we must say it was essential that, at least in my country, that the politicians recognize how important stroke is. So they asked the neurologists to come up with a concept, which was then taken by the state administration and made happen. And it's paid for by the states, and the running costs are paid for by the fees that the insurances pay for the patients that are treated. That's a big difference, and as long as there is still this private patients get best care, and because they can pay out of pocket and the others don't have access, it's difficult. But it's very important. The government will be forced to take a stand, because the WHO has just decided to make this drug that opens up vessels again an essential drug by the WHO. And being on the list of essential drugs means that every country has to report to the UN and the WHO how they are planning to make the essential drug available and affordable. And they have to report whether the report is a success or whether the report we could not do anything about it. But politicians don't like to report failure to the WHO. That's a big chance.
Can I just ask the questions, guys? Because I'm all for this Angels initiative, because I do have a mom who is a stroke patient. So I would just like to know from Mr. Fisher, could you give us a little perspective on the current needs of hospitals to be like stroke ready?
As I mentioned before, for the patient it's a lottery to come into the right hospital. So we normally say a patient has to come, must have the option to arrive at the hospital, stroke ready hospital, in 45 minutes. So you can just make a circle around the hospital and you see how the country is covered. And so if you're outside the circle, the chance that you have that you are treated with a positive prognosis is very small. But on the other side, as Professor Hacke said, the patient can be treated, and this we have to communicate to the politicians. Stroke can be treated, and so it's not a fate for the patient to get the stroke and not to be treated and to be disabled for the rest of his life. They can be treated, and this is not only you can not only prevent the disaster for the patient, for the whole family. You can also prevent the high burden for the society, because a disabled patient costs also a lot of money. I don't want to of course, to be disabled, that's horrible enough, but it costs also for the society. So politicians should be interested, and we see more and more countries who see this. Egypt, for example, they also decided to build up 46 new stroke-ready hospitals because they see it's important. And also here, the journalists were really crucial to communicate it to the ministry.
All right, some more questions, please. Yes, David.
So for Sir Thomas, I would just like to ask about there are currently 11 stroke-ready hospitals in the Philippines. Is there a target for you how many hospitals you're targeting to make stroke-ready? And what are the requirements for a hospital to be stroke-ready?
So I think Professor Planin already said that from the current calculation you need around about 360 stroke units, which seems to be very high. But you know, so we can do it stepwise. If you have now 30 hospitals, around about 30 hospitals, so it doesn't matter if you want to be at 360 or so every stroke unit they can add is a win. So let's go for the next 100, that we have let's say a realistic goal, and then to find out how this can be improved. For a stroke-ready hospital, you don't need so much as politicians always think. You know, you need a CT, you need, which is most important and which is a bottleneck in a lot of countries, but also specifically here in Philippines, you need neurologists who can treat stroke. So education of young doctors is important and crucial, including also stroke nurses, and access to the treatments for thrombolysis, thrombectomy in the best case. But you can also do quite a lot just doing basic nursing care. Just doing this dysphagia screening, so patients have problems with swallowing, they get lung infections due to aspiration, and this costs a lot, this makes people ill, they die or are disabled because this, not of the stroke, but of the secondary infection. So you can also do a lot of stuff on a broad level without having always access to the newest drugs or treatments. Of course, we should have this as a goal in mind, but you can start everywhere.